Here, I'm going to talk about a typical presentation for allergic bronchopulmonary aspergillosis in a patient, female, 78 years old, having history of bronchial asthma. Bronchial asthma was the clinical clue to diagnose allergic bronchopulmonary aspergillosis. Let's talk about this atypical ABPA. Here we have in the right lung, right upper lobe, there is bronchiectasis, mucus plugging here, and bronchiectasis here as well. This is in upper lobe, a mucus plugging, bronchocele. In lower lobes, again, we see a bronchocele and bronchiectasis. And here we can recognize the presence of finger in glove appearance, a description of chest X-ray, we can use it here, and or tree in bud in appearance in HRCT. So here we have the triad for chronic infection of specific etiology, but no lobar predilection, and it's unilateral. Bronchial asthma is a clue to diagnose the allergic bronchopulmonary aspergillosis in this case. Let's go to the mediastinal window here. Here you can see that there is high attenuation within the mucus plugging the bronchiectasis, and nicely shown here as well in the right lower lobe, bronchocele with high attenuation mucus sign. This is pathognomonic as a radiological sign for allergic bronchopulmonary aspergillosis. But suppose we don't have this sign, which is pathognomonic in HRCT, and we have these triad bronchiectasis, tree in bud, and mucus plugging bronchocele. These triads can be diagnosed or can be found in cystic fibrosis, allergic bronchopulmonary aspergillosis, immunodeficiency, and primary ciliary dyskinesia. Differentiation by imaging alone without HAM is difficult because here we have a typical distribution. Cystic fibrosis and allergic bronchopulmonary aspergillosis have tendency to occur in upper lobes, and primary ciliary dyskinesia and immunodeficiency has tendency to involve the lower lobes. But here it is unilateral, not diffuse bronchiectasis, so the algorithm is not applied here. So the helpful sign is the HAM, and the history is very important to diagnose the ABPA. Otherwise, we have a big differential diagnosis, including the 4 entities of chronic infection of specific etiologies. As we mentioned now, there are 4. They are only reduced into 1 diagnosis by this clinical history of bronchial asthma. Something else, it's not in literature, but according to my experience, this appearance of bronchocele, prominent bronchocele as a dominating feature, the striking finding that we can see here. Also, this is an indication for diagnosing allergic bronchopulmonary aspergillosis from experience point of view, because the other 3 entities, cystic fibrosis, immunodeficiency, primary ciliary dyskinesia, has tendency to present with bronchiectasis more. Even in allergic bronchopulmonary aspergillosis, it can be the only finding that you can see them here in upper lobes right and left, and you can see the finger in glove pattern in both sides without tree in bud, without bronchiectasis, and this is the appearance of ABPA. It has favor for mucus plugging more than the other differential diagnosis. In this patient, also to complete discussion of this patient has old TB sequelae, of calcific hilar lymph nodes and presence of calcific pulmonary nodule as well. So this patient is allergic bronchopulmonary aspergillosis on top of old TB sequela. Thanks for your attention.